now the host. So thank you very much, Jared, for that. So allow me to start the presentation today. Like I said, I'm a BSN graduate, and I'm pursuing public health at the School of Public Health, University of Nairobi. And I'm doing part 2, that is year 2. And we are, for the last 3 months of 2 months, I've been involved in this quality improvement project supported by Karolinska Institute. And we've been implementing the project in Kayole 1 hospital. We introduced, let me say, we conducted a training on the 3 techniques of midwifery care: delayed cord clamping, skin to skin care, and then dynamic positions of birth. So I would like to take you through the 3 techniques. So I think this will be important for the students as well as for the midwives at Kayole 1 facility. Maybe at the end of the presentation, the student could comment if this is something they have been taken through in their curriculum, or is something that they are missing, or is something that they have been practicing in the clinical area. So those are the 3 techniques. They have been recommended based on existing literature and also recommended by WHO. So let me start with the first one, delayed cord clamping of the umbilical cord. And this technique of midwifery care is highly recommended by WHO so as to reduce infant anemia. So what is delayed cord clamping? So by definition, delayed cord clamping is when you clamp the cord at least after 1 minute after the delivery of the baby. At least after 1 minute. WHO recommends between 1 to 3 minutes after birth. So that is what we call late cord clamping or delayed cord clamping. So WHO recommends this practice because it enhances placental transfusion of the blood, transfusion of the blood moving from the placenta to the baby. So this is important because the baby gets some adequate amount of blood so as to prevent them from or requiring post-delivery transfusion. So WHO recommends this practice despite a number of concerns and theoretical barriers to the practice. For example, there's been a concern about jaundice, so that if you allow the baby to have a blood coming from the placenta, so the baby will have a lot of, will end up having jaundice, the physiological jaundice. So, but WHO clarifies that this is not a concern because studies show that only 4.3% of the babies who receive delayed cord clamping blood will be jaundiced. However, there is no increased risk of severe jaundice or severe mortality coming from this jaundice. Then this practice can also cause polycythemia, but studies showed there is no concern from this polycythemia. Then there's been a concern about HIV transmission when you delay cord clamping for women, including HIV positive mothers. So WHO recommends that delayed cord clamping should be practiced regardless of maternal HIV status. Then WHO recommends integrating delayed cord clamping into essential newborn care and management of the 3rd stage of labor. So what are the benefits of delayed cord clamping? It increases the iron stores at birth and there is less infant anemia. It decreases intraventricular hemorrhage of the newborn baby. Studies show that 59%, there is 59% reduction in the rate of intraventricular hemorrhage in preterm infants when they have been delivered with delayed cord clamping. Then WHO recommends this practice because it contributes to less necrotizing enterocolitis, with studies showing that there is 62% reduction in the rate of necrotizing enterocolitis among preterm babies when there is delayed cord clamping. Then there is less infant sepsis and then there is fewer blood transfusions needed, with studies showing that there is 52% reduction in the rate of blood transfusion for low blood pressure among preterm babies when you do delayed cord clamping. So there's some studies I have included in the presentation, 2 studies that support this practice. For example, there is a study by Pogliani. They compared babies born by delayed cord clamping and those who didn't have delayed cord clamping, who had early umbilical cord clamping. And they wanted to know if this practice is safe, so in terms of HIV transmission. So this was a cohort study of mothers who are on stable ARV treatment. And data was collected from 64 mothers who are taken through cesarean deliveries. So from this study, they grouped the women into 2, those with the delayed cord clamping, DCC, and those with early cord clamping. So comparing the 2 groups, the risk of anemia was reduced at 24 hours and at 1 month age after birth. For the DCC group, the risk of anemia was reduced. Also, the mean hemoglobin concentration was higher in the group with the delayed cord clamping than the group which was delivered with early cord clamping. So they also found no increased risk for severe jaundice. And the authors concluded that DCC, delayed cord clamping, is safe for infants born to HIV-infected mothers, and it is a simple strategy for improving infants' nutrition and health outcomes. So there has been concerns about delayed cord clamping, because delayed cord clamping depends on the ability of just the blood to flow freely from the placenta into the newborn baby. So in some scenarios, for example, during cesarean section, because the level of the baby will be higher or will be at the same level with the placenta. So there might be very minimal blood moving freely from the placenta into the baby. So some studies, there is another practice called cord milking, whereby you're supposed to pinch the cord at the farthest from the baby, and then you're supposed to milk blood for 2 seconds towards the baby. So cord milking has also been shown to enhance this placental transfusion. So it is also evidence-based. For example, there's a study by Kaderia et al. Involving 154 newborns. So 75 were taken through umbilical cord milking, and the other ones, and the other group was taken through delayed cord clamping without milking. So from this study, they were able to show that there was a high blood, there was improved systemic blood flow in the group that had umbilical cord milking, and they were able to show that umbilical cord milking can be performed where the placental transfusion is not effective to ensure the baby has enough blood from the placenta. So that is after cesarean section, where the effectiveness of delayed cord clamping might not be optimal. So that is an overview of delayed cord clamping. I know at the end of the presentation, you might have some questions, and we will be able to discuss. So just keep your questions ready so that I can take you through the next technique. So the next technique we have been implementing at Kayole facility, Kayole 1 Health Center, is skin-to-skin care. Skin-to-skin care means the baby is placed on the mother's skin without any clothes or blanket in between, immediately after birth, as soon as the mother feels ready to hold her baby. Anything that is not absolutely necessary should wait until after the first breastfeeding is finished and the baby has been on skin to skin for at least 1 hour. So in skin to skin care, there should be no wrapping or swaddling of the baby. And this is what is discouraged. Swaddling of the baby, then putting them on the cot away from the mother. So this should not happen according to this practice, skin to skin care, especially within the first hour after birth. What are the benefits of skin to skin care? It keeps the baby warm, it releases oxytocin. You can see there's a conceptual framework here. There's a conceptual framework here there's a conceptual framework shows, for example, that early skin to skin stimulates production of oxytocin, and oxytocin is very beneficial for the mother and the baby bond, and also to enhance exclusive breastfeeding or to enhance attachment. So this will also reduce crying on the part of the baby. It keeps the baby's blood glucose more stable. Then it's going to reduce the sensation of pain for the mother and stimulates milk production. So skin to skin, immediate skin to skin care helps the mother to breastfeed more successfully. And this practice is evidence-based, as we are going to see. So an example of a study that shows that this is a very important practice is a study by Bransom, a prospective cohort of more than 21,000 mother-baby pairs. So they were studied using a logistic, and their data was analyzed using a logistic multivariable model, which included maternal intention to breastfeed, maternal socio-demographic characteristics, and the duration of skin-to-skin care. So the authors found a dose-response relationship between the duration of skin-to-skin contacts and the practice of exclusive breastfeeding of the infant. So maybe let me explain about the last statement, dose-response relationship between the duration of skin-to-skin contacts and the practice of exclusive breastfeeding. So as the duration of time a baby is placed on the mother's under skin-to-skin care, so the more the duration of time that the baby is in contact with the mother, the higher the chances that this baby will be exclusively breastfed. So that is what it means, a dose-response relationship. So as one increases, the other one increases. And this can be showed in this graph on the right side here. So as the duration of skin-to-skin care increases, this increases the chances that is the odds ratio of a baby being exclusively breastfed. So it is very, very important to increase the duration the baby is on skin-to-skin contact with the mother. From the benefits you can see, we talked about improves mother-infant interaction. However, in some scenarios, you might not always have the mother. So the question is, should we have fathers coming in to support skin-to-skin care? So that's a very, very important question. And I think one of the nurses at the facility, Kayole 1 facility, asked me that question. So I had to look up for literature that maybe could support or could explain whether fathers could come in and support skin-to-skin care. So there's this study by Shukla et al. That showed that fathers are as effective as mothers in providing skin-to-skin care, as shown in their study. So they conducted a randomized controlled trial involving 64 eligible preterm infants who are randomized into two groups, A and B, to investigate the effects of fathers and mothers in preterm baby pain control effects. So in group A, the first 15 minutes of skin to skin was done by mothers, while the next 15 minutes of the skin to skin care was done by the fathers. In group P, this was reversed, such that the fathers started and the mothers followed. So upon analysis of the premature infant pain profile scores, there was no statistical difference between the two groups. And the authors concluded that there is no statistical difference in the effects of pain control between the two groups, the groups where the fathers started doing the skin to skin and the other group where the mother started doing skin to skin care. So this implies that if you're in a clinical setup, the mother maybe needs resuscitation, stabilization, and everything, you can encourage the fathers to support skin to skin care. It is very, very important. So that is the second technique we have been implementing at Kayole 1 facility. So the third technique and the last one is the technique on flexible birth positions or the dynamic birth positions. So positions of birth can be classified into two generally. So there are those that are flexible and there are those that are not flexible. So by flexible, we mean they are able, a position is able to reduce the body weight on the sacrum or the pelvis. The non-flexible ones, the body weight is maintained on the sacrum. So an example of a non-flexible birth position is the rhizotomy position, because when the mother is supine, so there's a lot of weight. When the mother is supine or semi-recumbent, there's a lot of weight on the pelvis or on the sacrum. So therefore, the sacrum is not able to expand. The pelvis is not able to expand. A flexible position, an example is squatting or side laying, so that the pelvis is able to expand. So this is the pelvic girdle. And you can see the sacroiliac joints. They are very, very important for the expansion of the pelvis canal. So very, very important. So depending on the position you adopt during birth, the progression of labor can be affected. So these are some of the positions, flexible positions of birth. You can see the first one here. There's a picture here shows supported squat. So we have the nurse on one side, and then we have the link partner here. So this is a mom who is squatting. So this is one of the flexible positions we've been trying to implement at Kayole 1 Hospital. Then there is the side lying, this one here. And then there is the kneeling on hands and knees, leaning forward onto the chair, leaning forward onto the lap. So semi-sitting position is not flexible. So as you can see, there's a lot of weight the body weight is exerted on the pelvis, or the pelvic girdle, specifically the sacrum. So this is an unflexible position. And what we have been able to see from our observations is that in our public hospitals, you rarely see any other practice of birthing position. So most mothers give birth on supine position, semi-sitting position. So so we set out to be able to see if we can make some improvement on this. So what are some of the benefits of the flexible birth positions? They reduce perineal trauma, they decrease the risk of urinary incontinence, they are less painful, they increase maternal satisfaction, and they should be an option in respectful maternal care. And the positions do not add any extra cost for the health facility. So as you can see, these are some of the pictures during our first training at Kayole 1 Health Center. We were trying to demonstrate some of those positions, for example, squatting, On the picture we have a colleague, Esther Kimani, who was demonstrating. She's a doula, and she has been doing a lot of this, especially in private hospitals where women hire to be assisted in dynamic positions. So this practice doesn't happen in our public hospitals. So this happened during the training, while trying to demonstrate the dynamic positions of birth. Since then, the Kayole One Health Center has adopted teaching women during their fourth antenatal visit. They are trained, they are taught on how to do dynamic birth positions. So during their fourth antenatal visits, so as to prepare them for delivery and to improve the uptake of dynamic birth positions. So this is my colleague Frederick Miriti. During ANC, Miriti was trying to demonstrate side laying with Nurse Dungia here. So I happened to participate in one of the antenatal health education clinics, and it was quite impressive that they are able to prepare women for dynamic positions even before delivery. So this was quite impressive. There are some more pictures that shows different dynamic positions a mom can adopt. The question is whether the dynamic positions are supported by evidence. So I decided to pull out two papers that would explain whether these practices are evidence-based. So there's a meta-analytic study by Zhang et al. Of 16 studies consisting of more than 3,000 women. They were reviewing the effects of flexible birth positions on maternal health outcome in terms of the operative deliveries, the duration of second stage of labor, instrumental delivery, and cesarean section, and the duration of active second stage of labor, perineal trauma, and mother's pain and satisfaction. So the review showed that mothers who are assisted to give birth in flexible positions were less likely to experience instrumental birth, or even cesarean section. Mothers were less likely to experience severe pain. Mothers were less likely to have perineal trauma. They were less likely to have episiotomy and had shorter second stage of labor. So you realize that a meta-analytic study provides, I think, the highest level of evidence. I mean, it's a very strong study to support, for example, a practice. So the authors recommended that midwives should individualize maternal care in such a way that if a woman is at increased risk of perineal tears, such as primigravidas or those who are being induced, midwives can prepare the woman to give birth in a more flexible birth position that will not increase the duration of active pushing phase, and that will reduce the chances of pelvic floor injury and episiotomy episode. So the flexible birth positions are based on the MIMAL model of care. So they are part of this model of care, which emphasizes that to enhance delivery and to reduce injuries and to enhance maternal satisfaction, women should spontaneously push. By spontaneous pushing is a woman feeling a strong urge to push is encouraged to follow the urge, but not to exert a lot of extra abdominal pressure, which has been our practice. So then the second part of this model is that flexible sacrum position to be practiced depending on the choice of the woman, where the sacroiliac joints are flexible and they will allow flexibility of the pelvic outlet, squatting, standing, or on all fours. And the third part of the model is that you use a two-step principle of head to body birthing technique, where the head is born at the end of the contraction or between contractions. the shoulders are born with the next contraction. It's like giving birth with only 2 contractions. Yeah, so that the mothers will not have to exert a lot of pressure. An experimental study, another experimental study was conducted to see if the flexible birth positions can reduce the chances of a mother experiencing second-degree tears. And you know, a second-degree tear is a very, very deep tear, more than 0.5 centimeters deep. And it is a major cause of a fistula because it involves the rectovaginal fascia. So these are very, very serious tear that has been very, very common in our setting. So the authors employed a randomized controlled trial of 597 women, nulliparous women, where 296 were in the intervention group, while 301 were in the standard group. They adopted the MIMA model of care to study the effects of the 3 techniques in the MIMA model of care on the chances of a mother experiencing a second-degree tear. So the findings of the study showed that the MIMA model of care reduced incidence of second-degree tears among premiparous women. The second degree of the second stage of labor was shorter in the intervention group. So there's a typo here. It is the second stage of labor. It was shorter in the intervention group. So that is that technique, dynamic birth positions, evidence-based, and it's something we have been implementing at our study facility. So I would like to show you where we are in terms of the 3 techniques at the facility. So we have been trying to track where we are in terms of the delayed cord clamping technique, dynamic positions, and skin-to-skin care. So from this graph, you can see when we started, we didn't have any woman, for example, practicing any other position or position of birth. And that includes the flexible positions. Most of them were not doing the flexible positions. So I think that is the area we needed to improve as a facility and as a team. So after the baseline, so we went ahead and conducted some training on the 3 techniques. And we even demonstrated some of the techniques. So after the training, we were able to see some changes. You can see after 1 week, we were able to see some changes. The women were being encouraged to be able to give birth in dynamic positions of birth. I think the green part represents the skin-to-skin care. So it went up to 100%. And then the purple line represents the delayed cord clamping. No, the purple one represents the dynamic position of birth. And then the black line represents the delayed cord clamping. So we have had tremendous success in terms of being able to move from 0% in terms of the baseline, in terms of the delayed cord clamping. And right now, we are having about 75%, 70 to 75% of women being able to, of the midwives being able to practice consciously delayed cord clamping. So we also had some improvements in terms of the dynamic positions of birth in the first 3 weeks after the training. But along the way, I think this practice could not be sustained, and we are still trying to understand how to be able to sustain a practice. Once you train, then how do you make it sustainable so that after after you stop visiting, supervising, and visiting, so you are able to, the midwives are able to continue with the practice. So that's a challenge we have experienced, and we hope to be able to come up with a sustainability technique. In terms of the skin to skin care, I think the facility has been doing very well. While we started at 80, we moved to 100, and then we came back to somewhere below 80. Now we are at 70s. So it shows we are not really deviating from the common practice. The common practice is good. I mean, it's 80. It was 80% when we came in. So we just need to see how we can sustain the 3 techniques beyond the project timeline. So the project was supposed to end after 3 months. So we are remaining with about 2 weeks to be able to improve on some of these challenges. So that is the end of my presentation. I would like to stop from there. I hope by this time we have nurses from midwives from Kayole facility, so they'll also be able to comment with regard to the challenges we have been experiencing, and also maybe suggestions on how we can have sustainability of the practice. So the success so far, like I said, there's a lot of teamwork there. Antenatal clinics have adopted the training mothers, like preparing mothers for some of these techniques during labor. So we are seeing a lot of improvement, and we have a lot of support from the sub-county quality improvement team led by Esther Sangale. Yeah, so allow me to stop there and invite questions and suggestions. Let me stop there. Okay. Okay, can I invite Dr. Jebet to go first?
Yes, thank you very much, John, for that very good presentation. And I think there is quite a lot of learning in regard to the evidence-based practice that is happening in Kayole. One thing to note is that these things are doable, even in our setups, because Kayole is a public health facility. And it would have been good if maybe we had somebody from the ground to tell us exactly how they implement this. Just one thing that I picked out from your presentation is about the umbilical cord milking. I'm not very sure about how this is being done, because evidence also indicates that it is a practice that is outdated. But I think I like your last statement that you said, in a case where you have placental, the placental transfusion is insufficient, that's the point where you pick it out. Maybe we need more evidence that would tell us if this is something that is coming back or not. But otherwise, I thank you very much. And just to acknowledge, we have our director, Dr. Miriam Wagoro, and we also have 2 of our PhD students, Eva and Zila, and we also have our master student, Alice. Thank you for joining, and back to you, John.
Okay, thank you very much, Dr. Jebet, for the comment. I have not seen the practice of umbilical cord milking. I have not seen it myself, so yeah, you are right. And I don't know if it's practiced in situations where the delayed cord the delayed cord clamping is not effective in enhancing placental transfusion. So I'm not sure. But from the literature, it shows they are saying that maybe it's something that can be considered where the placental transfusion is not sufficient if it's to be done by DCC, delayed cord clamping. Yeah, so, and I agree with you. It's good we get to hear from the midwives at the facility. who have been involved in this project and have been trying to implement this project. So I would like to invite Esther Sangale to make some comments, and also invite one of the midwives who I'm not sure who has joined in. Esther Sangale.
Yes, hello.
Hello.
Hi, John.
Hi, Esther.
Yeah, Sankala here. I'm happy to see the progress of the implementation of the project in Kayole 1. And I remember when we visited in the sub county, and we were with the MOH, and he was wondering if such a thing is possible to be done in Kayole, in our facilities or in any of the facilities. But I'm happy to see that anything is possible. We just need to take the steps and try and implement. So I'm happy for the progress. I don't know how far we are into completing the project. I have not been able to join your team when we are visiting, but I have visited the facility about, I think, twice or thrice. And I've also inquired about the progress of the project, of which I was assured it is going on well. So I'm hoping that even after the end of it, the facility will be able to sustain the gains and continue implementing what they have learned, the new things, because I like your presentation. At least quite a number of studies have shown that other methods of delivery other than the normal one that we are used to, they are helpful, and they are also able to reduce quite a number of complications during delivery. So thank you for your presentation. Hoping also to continue working together, and hoping also even at the end of the project, you will also be able to continue following up to see that the facility is still what they learned. Thank you very much.
Okay. Thank you very much, Esther, for your kind remarks. We really appreciate your support, and also we will plan to see how we can be able to make a follow-up even after the end of the project, so as to be able to support the team in sustaining the practice. Yeah, so and that is one challenge we will be facing, sustaining the practice. Erica, I don't know if we have Erica, the facility in charge, or the midwife in charge of the facility, Frederick Miriti. Okay, I don't see Miriti in the team. What about Lillian? Okay. All right. So I can't see Lillian as well. Dr. Miriam Wagoro.
Hello, good evening, everyone.
Good evening, Dr. Wagoro. Welcome.
Yes, thank you so much, John, for that very good presentation. And thank you, everyone who has joined the presentation this evening. This is how we learn. We talk about transferring evidence to practice. So I'm very encouraged because you gave us a lot of evidence that has been used to inform practice. I acknowledge the presence of Dr. Jebet. Dr. Jebet is the head of midwifery and obstetric nursing in the School of Nursing of the University of Nairobi. And she's a very interested party to this. And we were meant to come and visit Kayole. We hope we shall be able to do that sometime before the project ends. Mine is to encourage us that this is a good practice. We can have some nurse midwife-led interventions to inform practice. We should not just be waiting for others to tell us this is what works. So I'm so encouraged by this presentation. I'm also encouraged by what is happening. In terms of this project, I'm in the faculty that is teaching capacity building for leadership for this kind of practice. So mine is basically to talk about the leadership, how the leader's role in initiating change. It may be in obstetrics and midwifery, it may be in mental health, it may be nursing administration, but as a leader, how do you initiate change and how do you sustain change? And so when John is talking about sustaining this change, it will be very important that we think together on how we are going to sustain the change that works and that is respectful maternity care. John, we have seen that we started from zero. We went on very well, but at some point started coming down. It is very important that we have said that we shall be able to identify the challenges that make us come down so that we do not reach the zero curve again. I think it's agreeable and the report is very good. I'm sure that you'll be able to share with the Karolinska team, and this will be a very good report. Thank you so much. I'm sorry I came in late. I cannot identify Ruth Muia. I can identify Mulongo, and the rest of the team. Even if I don't call your name, please feel acknowledged and feel welcome. We are here because you are. So thank you so much.
Okay. Thank you very much, Dr. Wagoro, for the kind remarks and for your support as well in the course of this project. So we have had logistical challenges, but we will plan to see how the faculty can visit the facility in the course of next week to meet the team at the facility. Because we plan to maintain the relationship, the professional relationship beyond the 3 months so that we can sustain the practice. Yeah, so we will be able to do that. Thank you very much. So allow me to invite Miriti. Miriti is the head midwife at the facility. From my presentation, you saw him demonstrating some of the dynamic positions during antenatal clinic. So he has been doing a good job collecting data and everything. So Frederick Miriti, could you kindly say hello to the team and maybe comment with regard to the presentation, and maybe you can comment about the challenges you have been facing while trying to implement the 3 techniques of care at the facility. Okay, Frederick. Okay. I am not sure if Frederick can be able to.
Looks like his microphone is not working.
It's not working. Okay. We have Maxwell from the facility. Maxwell?
Yes, John, good evening.
Good evening, Maxwell. Welcome.
Thank you for this opportunity. Good evening, everyone. My name is Maxwell Tieno Dede. I am a nurse at Kayole 1. In the course of the training and in the course of implementing all that we have learned, we have encountered many challenges. And one thing I would like to say is that I would love for you people to visit so that you can be able to perceive the challenges that we go through as a team, because there are many, and some of them we can't say all of them, but some of them you should come and view for yourself and see how the project is going on. All I can say is that we are trying our best on the field, and we thank you for this initiative to be able to learn.
Okay, thank you very much, Maxwell, for your comment. So we'll plan to visit the facility so that we can understand what happens at the ground level. You know, it's one thing to be told what is happening, the challenge. It's another thing to visit and see. Yeah, so very, very important that we visit. Esther has also requested that when we visit, we should be able to update the sub-county health management team on the progress of the project. We will gladly do that. So that is before the end of the project. And even after the end of the project, we hope to convene again in such a forum. If it should not be possible to do an in-person meeting, so as to be able to present the findings and the overall report about the project. So we have our students from the university. You're welcome to ask any questions with regard to the 3 techniques, and then we can discuss based on your concerns or questions. Anyone who would like to ask any questions, you're welcome. So this is your opportunity. So from the chat section, I can see the request for us to share the presentation. Kindly share your email address. So I'll just type in my email address so that you can send your request, and so that I can just forward the presentation to you. So just type in my email address so that I can, after this, I can be able to share the presentation with you. So in the meantime, anyone with a question with regard to the presentation, with regard to the practice? Jared, you said you're a student leader. Any concern about the presentation, or is it something you've been practicing at the hospital?
Thank you so much, John, for that question. I have not yet rotated at the midwifery at the maternity. I will soon, but now I had a question. I don't know whether I was supposed to read about this or you can answer, but about different back positions and skin to skin care. Now we have these different birth positions now. So after probably delivering the mother, do you take the mother close to the bed? Okay, for example, the squatting position. So the mother has delivered in a squatting position. Do you hold the baby and then tell the mother to lie, and then you put the mother there, or how does it happen? So that this one is not delayed and probably the child is not hurt with the movements and all.
Yeah. Okay. So thank you, Jared, for that question. So Dr. Jebet, I think she can be able to respond to that. Before then, maybe I can give my view based on what we have been able to practice. So some of these positions require that if you are one nurse, some of these positions might not be possible. For example, the squatting position. So you'll need, I think you'll need at least 2 people supporting the mother in the delivery, on a squatting positions. because you'll need someone to hold the baby, so the baby doesn't slip out and hit the ground. So that will not be good. So you need someone to support the baby when the mom is squatting. Then you'll need 1 or 2 people supporting the mother as she's squatting. Yeah. So you need 1 or 2 people. One could be the husband or the partner, the delivery partner, and also a midwife or a nurse. Yeah. So you can see you'll need at least 3 people if we were to do it the right way. Yeah. So, and I think that is one challenge the midwives would have expressed, that if you are one midwife, for example, and you have 2 women, and they have requested to deliver on a squatting position, and in some facilities, you rarely see men or birth partners or husbands coming in to support mothers during delivery. So you can see that will be a challenge, and maybe that is one problem the midwives could be facing to sustain the practice. Yeah, that is in terms of the staffing and the capacity. Yeah, so you'll need at least 2 people to be able to do the squatting position. To support, one supports the mother, the other has to support the baby. Yeah. I hope I've been able to answer your question, Jared. Or maybe if I've not fully answered your question, Dr. Jebet can respond.
Okay, maybe I just add one thing into what you have explained, John. The whole idea of the dynamic birth position is to have the shortened second stage as much as possible. So I think what Jared wants to know is, once the baby is out, what will happen to the mother? Will she continue to be in that squatting position, or what will happen? So at this point, you may want to deliver the placenta. Sometimes the placenta can deliver itself by maternal effort. And then now you would want to put the mother on a supine position so that you examine the abdomen and the rest of the birth canal. Thank you.
Okay, thank you very much, Dr. Jebet. Any other question?
Thank you so much for the responses.
Okay, welcome. Ruth Moya from the chat. Could you ask your question? It's not clear from the chat. Ruth Moya, could you just voice out your question?
I'm sorry, I wasn't able to complete the chat.
Yeah.
I disconnected at some network challenges. Yeah, sorry about that.
Okay.
My question was meant to figure out in the context of the human.
Hi, Ruth. I think we lost her. We can't hear from her again. Okay.
Yeah, that was my concern. I was thinking perhaps if that was feasible, then it would be a strength that needs to be recommended and supported. Just being able to articulate those 2 processes at the same.
Ruth, can you hear me?
Yes, thank you.
Ruth,
yes, I can.
Yeah, could you repeat your question? I think we lost you at some point.
Thank you. Sorry again. I seem to have network challenges.
Okay.
And that's how I'm disconnecting. I wanted to type the question. However, I can just raise my concern. My concern was whether it is feasible to have one midwife to be able to continue supporting the mother in squatting position, and at the same time be able to receive the baby, particularly if there are no complications.
Oh, yeah. Yes, I heard your question. I don't think it is possible for one midwife to do that safely. because you might have the mother requiring that you support her. At the same time, on the other side, you can have the baby coming out. So I don't think you can do that alone safely. Yeah. But if you have the birth partner or the husband, I think that can improve safety when you're doing the squatting position. Okay, yeah, that's what I think about your question, Ruth Moya. Yeah.
Thank you. Thank you.
Okay. Okay. All right. Any other question, concern?
Hello.
Yes,
Hi.
Mocheche, go on.
Yes, yes. So I have a question. So in other presentations, which are far away from the normal presentation, do we have the lady still going into the dynamic position? And if so, how do we even do some of the maneuvers like Marisu maneuver? Is it feasible?
I'm not conversant with that question, being able to respond to that question. Dr. Jebet, could you respond to that question by Mocheche?
Yeah, thank you, John. I think Wendy wants to, is asking, Maricel's Melivec maneuver is in breech position. So that would mean if the client is having a breech presentation, of course, the position that they're going to birth this mother will change, except if it is a spontaneous breech. But if you need to intervene and do the maneuvers, then you may need to put this patient in lithotomy and make the patient very close to the edge of the bed so that it can allow you to do the maneuvers. That's how I would look at it. Thank you.
May I say something?
Okay, yes, go on, Dr. Wagoro.
Yes, I think in every situation, we have the purpose. The purpose is to shorten the second stage of labor. And if we have any conditions that will compromise that, then we may not be able to use, leave alone these flexible positions that we are being taught about today, that any other position or any other method that will compromise that kind of facilitated delivery or second stage. I don't know if the situation has changed now, but where I did my midwifery, any breech presentation in labor was always an indication for cesarean section. I've not practiced midwifery for long, so it may have changed, but that's what we used to do. Again, maybe I may ask the practicing midwife, Dr. Jebet is a practicing midwife, if the MOH policies have changed. Thank you very much. And then even when we are being taught these positions, we should be able to know that in every intervention, there are always contraindications, or there are always where you need to take caution even as you intervene. So all that is not lost in this new dispensation that we are going through. Thank you very much.
Okay, thank you, Dr. Wagoro. That's a good input. The practice has not changed in terms of the breech delivery. They are still treated as elective, except in a situation maybe like you're delivering a multiple pregnancy, and then the second twin is a breech. That's the time that you may, if the indications allow, you may conduct a vaginal birth. Thank you.
Maybe I can also add to what Dr. Chebet has said.
Yes.
Again, I want to concur with Dr. Chebet that we do no longer manipulate breaches, especially in diagnosed in good time. However, there are situations that you encounter breach at second stage, and where the situation does not allow, perhaps distances and no, maybe timings, and you have no option other than to try and do what you can. In that context, then manipulation of breach is allowed. Thank you.
Okay, thank you. that contribution, Dr. Wagoroe, Ruth Moya, and Dr. Jebet. Any other question? Okay, welcome. Any other question? So maybe I can ask you a question now that it appears we are not having any more questions. So the question I think we've been struggling with is how to sustain the practice beyond the 3-month timeline dedicated for the project. So any suggestion on how one can sustain the practice, the clinical practice after you've done the training and then you've left? So maybe Esther Sangale or even our master student and the PhD student, any suggestion on how to sustain a clinical practice? For example, the 3 techniques of care, they have been shown to be very effective. If you look at, for example, delayed cord clamping, so this has been shown to prevent iron deficiency anemia. And iron deficiency anemia is associated with neurodevelopmental disorders. And imagine that you have a baby suffering from iron deficiency anemia, suffers from neurodevelopmental disorder from that young age, and that will carry into their adult life. So they will not get a good job. So you can imagine the cost implication, the productivity cost, indirect cost. Some of them might not be very, very bright in school, so they might need some child support. So so some of these practices are very, very important. So how do we sustain such a technique after you've gone in a facility and you've trained and you want this to be happening? So anyone can just respond and give their suggestions. Yeah.
John, can I contribute on that question?
Yes, go on, Maxwell.
I think in terms of continuity of the program, even after training, if you are together with a nurse on duty, maybe you are 2 or 3, you can be able to encourage yourselves, because once you are taught something, it is upon you as an individual or a group to be able to continue something. You know, if you as an individual or as a group, you don't want to continue with something, then it can't go on. But if as a team or as an individual you want something to continue, you can be able to do it by encouraging each other to be able to practice it often. Thank you.
Okay, thank you very much for that contribution. So Maxwell is talking about, I think it's the motivation or the drive, the in-person drive to be able to pursue excellence. So that is so I will go ahead and ask, how can we inculcate that kind of discipline in the clinical setup, whereby once someone has been trained, they can have that morale to be able to continue the best practice. Yeah. Anyway, thank you very much, Maxwell, for that contribution. Any other?
John, this is Eva Maina. I think I have something to say on sustainability. Can you hear me?
Yes, Eva, I can hear you. Please go on.
Okay, yeah. So I was thinking in terms of one, ownership of the program or the practice. And this is by involvement of stakeholders. glad to hear that the MOH and the sub-county health management teams are on board. So these are some of the stakeholders that will ensure sustainability, and also the nurses in the facility, as Maxwell has talked about, because for people to sustain something, they must own it. And then after, and also other relevant stakeholders who are interested in this that can come on board, maybe a non-governmental organization, training institutions, and also support supervision is very important when we talk about sustainability. And capacity building. And that is if capacity building is done at the relevant levels, the MOH, the sub-county health teams, then they're able to give support supervision to the practicing nurses. So that's my contribution on how sustainability probably can be ensured. Thank you.
Okay, thank you very much, Eva Minor, for your contribution. You talked of ownership of the project, very, very important. Support, supervision, and capacity building at relevant levels. Yeah, so we'll heed to your advice. We are, I think, almost completing the project, and we have been able to work closely with the sub-county health management team, headed by the MOH, and also Esther Sangare is in there. So we hope to be able to involve more stakeholders to be able to make to have this project being able to be sustained after our stay. Yeah. So we are 5 minutes past time. Maybe we can give one more comment or question as we come to the end, as we close our meeting today.
Let me just say this before you close, on sustainability, perhaps mentorship of the team who you're working with. I know I missed a little bit of the initial presentation, but embracing mentorship of the clinical team who you are working with may ensure that they're able to carry it on when you exit. That's one. Okay. And the other would be maybe scaling it a little further beyond the facilities that you are in. So that maybe several other more facilities, even if it's in the same sub-county, are also practicing the same approach, mentorship, scaling it up. And then again, observing, documenting this, making recommendation to improve. I heard you clearly saying that there are some challenges, especially in the context of shortage of staff. So if we could think through some of the recommendations around those challenges and suggestions, and then we keep on encouraging the same facilities to try and improve the practice with some of the suggestions that you'll have made, then perhaps they would make policy statements that could be incorporated in the policy documents and then influence the wider country at the policy level, and also influence the training, the pre-service and the in-service training to get the practice and be carried on beyond your existence. Thank you.
Okay, thank you very much, Ruth Minor. I think you've reminded me to ask a question to a finalist nursing student who could have rotated in the maternity units. So I think we have Barnes. Is Barnes still in the team? Or do we still have a final year nursing student who has gone through the maternity rotation and they would like to share their experiences, whether they have been able to do this in clinical practice? Neema? any student who has gone through the clinical rotation for maternity and they would like to share whether they've been able to experience some of these techniques? Okay.
Hello.
Hello, Mochacha. Please go on.
I was saying I went for the rotation, but it was cut short after a while. But I was able to witness skin-to-skin contact and delayed cord clamping. For the dynamic positions, it is a novel practice for me.
Okay. So you're saying for the skin-to-skin you have practiced, but the dynamic positions you have not practiced during your clinical rotations.
Yes.
Okay. Thank you. So maybe a comment to Dr. Jebet, or maybe she can comment. Dr. Jebet, do we have this like dynamic positions in the curriculum?
Thank you, John. Yes, we do. The challenge is our clinical placement areas are KNH and Pumwani, and those facilities are quite busy. Sometimes we have 2 or 3 clients sharing one bed, and so you can imagine if you have 3 clients on one bed and then you bring in the relatives, it becomes a big challenge. Like KNH label right now, because of COVID restrictions, does not allow any visitor. So it might be a little difficult to have this kind of practice. But in the curriculum, it's actually.
Okay. Yeah, so thank you, Dr. Jebet. So it is in the curriculum, but this is translating what is in the curriculum to clinical area is a challenge. For example, right now, we have COVID, so we might not even have birth partners being allowed into the facility. And also, you've talked of the fact that we have overcrowding in our health facilities, which is the case in most government hospitals. For example, if you go to Thika Level 5 Hospital, County Referral Hospital, or even Kenyatta now, yeah. So you have mothers sharing a hospital bed. Or even mothers, if you, let's say, for example, in the place where I did my internship, that is Thika Level 5 Hospital, we had 3 delivery beds, and we used to have about 10 to 15 mothers in active phase of labor. So you can imagine a situation whereby you have so many mothers requiring the hospital bed, so many mothers, for example, in second stage of labor. So you're not able to deliver quality or to individualize care or to give enough attention to one mother. So that will be a challenge in translating what is in the curriculum into practice. And that, like what Ruth Moya was talking about, some of these changes can happen at the policy level in terms of staffing and maybe decongestion of the hospitals. So some of those will be systemic changes for us to be able to sustain some of this practice. So allow me to say that we have come to the end of this meeting. We are past time, but I want to thank you for your patience. And we look forward to be able to hold another discussion like this one, just to update you on the progress with regard to the implementation of the 3 techniques at Kayole 1 Health Center. I want to thank Esther Sangale and the team at Kayole 1 Health Center for being stakeholders and for supporting us and for supporting the implementation of this project. We hope to continue working together. Thank you, Dr. Wagoro, for facilitating this and for bringing the students on board and Dr. Jebet, and everyone, the master students, the PhD students. So thank you very much. We have come to the end of the discussion. I will be sharing the presentation with you. Thank you very much. Asanteni sana.
Thank you very much.
Okay, bye-bye.
Karibu.
Thank you very much for organizing, and thank you very
Thank you,
much
bye.
for attending. Thank
Karibu.
you.
Okay, asanteni sana.
Thank you, John.
Okay, asante.